Firstly, I just want to thank Angels for this opportunity and just to provide you our success story in South Africa. These are my disclosures. So internationally, we know that every 30 minutes, a stroke patient who could have been saved dies. In South Africa, stroke is the 4th leading cause of death, and this was our mortality statistics last year, contributing to 5.1% of total deaths in our country. Those of us that work within the field know that this is a complete underestimation of the actual stroke burden in our country, as this is collected or this is generated based on mortality statistics. If we look at a differentiation according to sex, stroke is more prevalent under females and predominantly Black African females. Current strategies in South Africa were fragmented. No stroke units, except for one maybe in Cape Town. There were no standardization of standard treatment protocols. The staff were generally poorly skilled, with no treatment protocols, and we have no form of actually monitoring how well or how bad we are doing. So in 2016, with the help of Angels, we established our South African Steering Committee, and these are just some of the members. And the Steering Committee comprises of both public sector as well as private sector physicians, neurologists, radiologists, etc. We, over the past 2 years, have set out to partner with various stakeholders. These are all the private sector hospitals in our country, which serves around about 16% of our population. If we look at our government stakeholders and partners serving 84% of our population, we received endorsements from the Department of Health, the South African Stroke Society, the Heart and Stroke Foundation, and even the Emergency Society of South Africa. Furthermore, we also gained collaboration and endorsement from our academic institutions, and these are just some of our academic institutions in South Africa, with the main ones being the Wits University, Stellenbosch, and UCT. So the main focus in our area is multi-pronged. Because we realized that the challenges we faced were so enormous and diverse. The main focus of our training, our support, has been to improve pre-hospital delivery of patients, so by means of education and pathway optimization. The second target was to establish these centers of excellence and provide reading material, training, simulation training to doctors within these centers, and then also focusing on public awareness. So looking at the Angels Initiative, those of us that are part of this, there are essentially 4 platforms to ensure and to maintain the success. And it's obviously founded with standardization of treatment protocols, our Angels consultants who we could not do this work otherwise, awarding the hospitals in our network that are doing well, and essentially building a community, this network of like-minded people supporting one another. So our consultants, when they arrive in the hospitals, they essentially focus on 5 points within this patient pathway. As I already mentioned, the main focus or big focus is on pre-hospital phase, where we engage our emergency medicine colleagues, train them, try and optimize pre-notification. Then within the hospitals, we focus on hyperacute care, optimizing our door-to-needle times. Within our country, because radiological services and specialities within that field are so limited, we had to think outside of the box and also provide training to our junior doctors with regards to decision-making where it comes to CT interpretation, as well as deciding who the patients will be that we will TPA, and then obviously focusing energies also on the establishment of stroke units. So what the steering committee did, we took the international-based material and we localized or adapted and modified it for our local setting. Okay, blank slide. And we also then developed patient awareness material that we give out to our patients, our doctors, the healthcare providers, etc., with the main focus that we need to act fast, and then obviously strategizing with them on how to optimize their pathways. There are blank slides. Okay. These are just some of the patient material that we provide and give out to our patients. What we then also decided was that we needed to take the show on the road. And 3 months ago, we launched the Angels Initiative Roadshow. And this is just sort of a representation of all the provinces in our country that we will be providing training within those provinces. We've got 9 provinces in the country. This was the roadshow in Bloemfontein, and the main focus, similarly to what Dr. Martins have done in Brazil, is to take material, provide training, simulation training, decision-making training on CT, and facilitating the community in that area to improve their stroke care. We were the second, so I'm based in East London, so we were the second province that the training happened, and the bottom picture is just some of my rehab team in sort of taking the hashtag Saving Lives campaign further. So if we look at the current status in our country, we have around about 125 hospitals where training had taken place, simulation training that are being supported by our consultants, and in every one of those hospitals, there are stroke champions, with a target of, in December 2019, to have 165 hospitals stroke ready. So we are well on our way to reach that target in 2019. So I actually just wanted to take the next few slides to show you how we practically implemented these pathways within the hospital, specifically my hospital. So in the end of 2016, beginning 2017, I launched the stroke readiness program at my hospital, and we decided to use the very challenges that we have, use them to actually initiate change and to progress. Predominantly, the 4R approach was that we were not recognizing the acute stroke, we were not activating an acute stroke protocol, we were slow, and the availability of the TPA within our hospital was an issue. So if we look at the recognition of the stroke, the main challenge that we still face is the delayed arrival by the patients. They often come beyond the 4.5-hour window. But that was not limited only to the patient, as we found that the healthcare practitioner response, as well as those from the emergency health services, were also delayed and were also slow. So we set out to improve that, and this is just some of my team members, how we went about at the hospital and trying to bring about a greater awareness of an acute stroke. For those of you that know or don't know, so the main mode of transport in South Africa are these minibus taxis. So earlier this year, we branded these minibus taxis, and it was amazing the amount of conversation it sparked, seeing this blue and green taxi driving around in Soweto. And you know what, quite frankly, with the challenges we have with EMS, I would not be surprised if these minibus taxis actually start delivering the patients to our hospitals in time, literally. I also joined up with the Heart and Stroke Foundation, and this was one of our awareness campaigns that we did at schools within our country. So when we look further, and this is just some of the data in my hospital, when we look at the symptom onset to door time, you can see that it's still varied across the number of patients that we have been able to thrombolize. So in about 14 months, we've been able to thrombolize 20 patients. As the patients still arrive very late. One of the big things that I initially thought was the reason was the EMS response, to the calls being received from these patients. And I've set out then to train the EMS responders. This is quite a first for South Africa, where both public and private sector service providers come around one table to improve stroke care services. When we then looked at the second challenge was, right now, the patient arrives at the hospital, but then we would miss the patient within our triage department because we didn't triage them adequately. When we also looked at that, we thought, okay, but what is the issue? Because most of the patients are actually arrive at the hospital actually being walk-ins. And it's known that if you come with an ambulance and you're on a stretcher bed, you are more likely to be triaged quicker versus if you actually just walk into the hospital. So what did we do? When you enter my hospital, the first person you see is a security guard. And lo and behold, he is the biggest stroke champion in my hospital. Because if you bleed, he will let you through the door. But if you are just walking in, or maybe someone pushed you in the wheelchair, he would actually have told you to go and sit down. So my first point of call was making a big deal of Isaac. That's his name. And now he's the one that triages you even before, as you enter the door. Isaac is further supported by the development or the establishment of an actual triage room, where he will take you to. No, it really. So if we look in South Africa, the biggest challenge is our South African triage manual. We've got this color-coded system, and based on symptoms and vital signs, you will be scored and graded. So if you are green, it's known that you are allowed to wait more than 4 hours in the hospital. If you are orange, for instance, you would be escalated quickly, and if you're red, you go in immediately. Now, stroke in South Africa was not a priority before, other than chest pain for MIs. So we had to change that, and I'm going to move quickly. So in our hospital, we then moved stroke. We gave it a higher priority, and this is just our triage scorecard. Next thing we had to do is we had to now react. Now they're arriving, we are triaging them correctly, and we now need to react. This is our stroke protocol in our hospital. What we also did was we bypassed casualty and go straight to the CT room. No need for a folder, and we developed our stroke algorithm. We moved our TPA to our CT room, where it's above the CT, and we TPA on the table. And as you see, we dramatically reduced our imaging to needle time by just doing this single intervention. If we look at our door to needle time, and if we apply the target stroke definition, 95% of our patients arrive within the 60-minute cutoff with a door to needle time of 47 minutes average. Those guys that are doing so well now, it's been shifted. So if we then apply that rule, we're just under the mandatory 50%, but we're getting there. And this is why we do what we do, is to reduce our NIHSS scores, which dramatically improves, and also increasing our dysphagia screen. So now more than 70% of our patients will have a dysphagia screen within 24 hours. I just wanted to show you this video of one of the patients that we thrombolized.
Or should we put another line?
Tata, kau pakai misa engalo?
So he's got a right-sided hemi.
Yeah, you can run it for a while. But listen, just hold on before you start going.
So it's a 63-year-old gentleman.
Sure.
And at this point, he was actually diagnosed as having undiagnosed hypertension. So this is after the bolus
Lift ingalo?
initiation of the infusion.
Hey, pakai misa mlenze?
So he's asking him obviously to lift up your arm, lift up your leg. And just in the interest of time.
Paku, yeah. Pakai misa mlenze. Kakuru, whoa! Inkosi tata.
Can I just say the neurologist, i.e. me, was fast asleep at home. So just to prove the point to you that you do not need the specialist to be able to do acute thrombolytic care. And the lady that you heard in the background, that's actually a junior doctor that did the thrombolysis. So stroke mortality, morbidity are on the rise. We all know that. Hyperacute and acute inpatient management is possible, and I've proven that to you in an under-resourced setting, but we still need to standardize and establish quality of care indicators, stroke registry in our country. Thank you, Prof.